fantastic to see so many of you out tonight to listen to Dr. Shen's presentation. Before we get started, I just want to go over kind of some of the background behind these events and some of the other things that we're offering. So our mission at the cardiovascular team here at UniPoint is to take care of the hearts of our community so that people live happier and healthier lives. So that's what, getting together tonight, listening to Dr. Shen, this is all about just keeping our hearts healthy. So for happier and healthier lives. Now, as far as events, we have a new event that we're just releasing tonight and that is we're going to put together a team for the American Heart Association walk and the UniPoint cardiology team, and we'd love for you to walk with us. So it's going to take place June 10th, that's a Saturday. It starts at 9 in the morning. Dogs, pets are welcome, strollers. We will go at a very comfortable pace. It's 5K. And we have t-shirts that we will have available at the next Heart to Heart, and they'll be available probably in the next, for sure, 2 weeks. We're trying to get them as soon as possible in the gift shop, and they'll be $25 the t-shirt. We have a variety of sizes, and we're actually going to have V-neck too available. And the funds raised are going to go to an ultrasound machine to assist with the IV access for the cardiology patients and a treadmill for cardiac rehab. So those are, great things that we're raising money for here, right here in cardiology. So if we're sure there's going to be great weather. So we'd love to have you join us there and walk together. And as many of you have experienced with me, we do more than just educational events. We have hands-on experiences, the cooking, the culinary nutrition classes, and those, we have a couple coming up in May. We have the Cooking with Heart for Cancer, anybody touched by cancer, or just, wants to know more about food and anti-inflammatory. So that will be starting May 2nd. That's at noon in the Heart Center kitchen there, or we have the virtual option. And then May 4th, Thursday evenings, we'll be doing a foundational. That's 4 classes that we run for each of those. And then the next diabetes will be in June. So those are things, think about inviting somebody to go along with you. It's a lot of fun. So I've had many of you in the classes, so I love that. So consider that for keeping your heart healthy. And these are the different ways to contact us. We've got the email, the phone number, and we've got the new website there. So those are the different ways. We have the heart newsletter. So if you're not getting the heart newsletter, because we'll release stuff about the heart walk too there, let somebody know, myself or Kathy or Dan know. We'll get your name and your email down. Okay, so let me go ahead and introduce Dr. Shen. So he's a board-certified cardiac electrophysiologist and cardiologist specializing in treating patients with heart rhythm disorders. He completed his electrophysiology fellowship at Northwestern University in Chicago, his clinical cardiology fellowship at Indiana University, and he's a director of cardiovascular research and education at Cardiovascular Medicine. He's passionate about bringing the latest advanced technology and clinical trials to here, the Quad Cities, and he enjoys spending time with his wife and his 2 boys. So please help me welcome Dr. Shen.
Thank you very much. Thank you. Thank you, Dorisa. Thank you for the opportunity to talk to you about this. In my opinion, this is a very important topic. I'm going to talk about cardiac implanted electronic devices, pacemakers, defibrillators. So I just want this presentation to be very interactive. A lot of Q&As. Feel free to ask any questions. And I'll start with one question for you. So I see some familiar faces. Some of them, some of you are my patients. Who among you, and if you don't want to answer, that's okay. Who among you have cardiac pacemakers, defibrillators, or any implantable devices? Okay. Who among you know someone in your family or friends have implantable devices? So pretty much everyone. And I think, this speaks for the prevalence of these cardiac devices. And whether you self have it, or your friends have it, or maybe you or your loved ones are gonna have it, I kind of summarize through the past few years of my practice, very commonly asked questions, and you might have the same questions as well. And I try to kind of summarize them together and kind of answer that for you. And if you still have more questions, I'm sure there will be. Feel free to ask at the end, okay? So my topic is cardiac implantable electronic devices. And I bring some samples from these company members with different devices. And if you're interested, feel free to kind of, feel for it. You know the size and the weight, and then, how and where they put in. So that is the, samples over there. So this is my format for today's presentation. For me, the initial presentation will be 2 minutes, all right? And I'll summarize the questions and I try to answer. There will be another maybe 30 minutes or so, and the rest of them will be for you. So FAQ, Q&A session, and hands-on is over there. That's kind of the 3 parts. These are one of my presentation slides. It's probably the only one. I just want to use a big slide showing that over the last 50, 60 years, maybe a little longer, the evolution of pacemakers. This is a pacemaker. So this is one of the company pacemaker. It used to be like huge, and you have to wear it outside of your body, right? And then the wires, they got to kind of screw in outside of the heart. This is, maybe 15 years after World War II. So, some of you, maybe most of you are alive at that time. So this is not too long ago. Yeah, so this is not too long ago. And see that after decades of evolution, the pacemaker has becoming smaller and then more longevity, function. And then now, the latest technology is we put it inside the heart like a bullet. And I'll talk a little bit more about that. Same thing kind of applies to, other companies and defibrillators as well. So the trend of the evolution of cardiac implanted electronic devices, it's kind of a big word, but basically pacemakers, defibrillators, is getting smaller. Hopefully it's not getting bigger. All the cell phone is getting smaller and smaller, and then now it's getting bigger and bigger because, people complain it's too small. But I think for devices, we don't have that kind of question. We want it small. We want to be smarter as well. What does smart mean in devices? For example, for a pacemaker, we wanted to track your activities. So people get a pacemaker really because their heart rate is slow, or if their heart rate is not able to meet their physiological demands. So when you exercise, your heart rate is supposed to go up, but instead, if you have your biological pacemaker, your heart intrinsically is slow, your heart rate cannot keep up. So nowadays, the pacemaker is able to track either your activity level, your breathing, and some newer pacemaker even track your body temperature and provide a faster heart rate. And that is still not nature, but it's close to as it can be. It's definitely smarter than, just set the heart rate of 60 or 70, just let it be. The newer devices have a longer battery life. This is a little bit of a counterproductive for the company. So I think they have technology to really extend the battery or do, wireless charging for their battery. But, I think, it's not of the company's interest to develop a battery will last for 50 years. They want to sell batteries, but I think with healthy competition among companies, they still come up with longer battery life. So I welcome that change. Remote monitor. So for those of you with the devices, the benefits of remote monitor. The remote monitor allows us to monitor your device remotely. And historically, people have to come in every 3 months to get a device check. and then use the telephone and, put a magnet on and see how your magnetic rhythm. And now people get a pacemaker or a defibrillator, they go home with a machine, we call it. We put it by your bed, and that machine serves as a bridge between your device and our device clinic. So anything happen on that particular day, when you get close to the remote monitor, that machine, the information will be relayed to our device clinic. If there's any alert, we know it right away. A lot of studies have shown remote monitor reduce hospitalization, reduces complications, detect any heart rhythm issue, pacemaker devices related issues early on, so we can fix it early, okay? We can detect early. Remote monitor is a big breakthrough for the last several years. MRI compatibility. So nowadays, we put in devices predominantly MRI compatible or conditional. A lot of wires that was put in several years back were retrospectively approved for MRI use. But the battery we put in predominantly is MRI compatible. When I say MRI compatible, that means you still have to let us know. And the radiology department, they're going to do an elective MRI, they let us know. The reason is we still have to have the device checked before and after it, set it to a specific settings so that the MRI can be done safely. Once the MRI is done, we will revert and we'll check the device and make sure everything is okay. That is a big breakthrough as well, because a lot of older devices, they're not MRI compatible or conditional. Staying outside of the vessels, that is a relatively newer concept, but the traditional devices are typically run the wires inside the vessels. That generally is okay until the lead or the wire becomes an issue. Lead and wires are just like all these electrical cables you see. They're moving with your heart, they're moving with your body, they're not immune to wear and tear. Once they wear and tear, then we have to replace it. And if your body gets infected, sepsis, pneumonia, UTI, your body gets infected, the whole thing has to come out. So if a person, especially a young person, get a device, we strongly argue getting a device staying outside of their blood vessels. And I'll talk a little bit about that. Smartphone app. So everybody pretty much has a phone right now. And with the phone, they kind of change how we live, right? So teenagers, they can't live without their phones. And I would argue now, even if you're 70, 80 years old, once you get a phone, you feel like you have a whole different world. It's so easy to use your phone. The app can manage your device, can monitor your device, can let us know. So I think with a smartphone app, they kind of allow us or the patients to kind of monitor their device. They can see, their device situation and, some trends, and that is kind of useful. And artificial intelligence has been really popular. It's kind of a buzzword these days. And that has been very useful in pacemakers and defibrillators management as well. I think down the road, right now they're somewhat limited to certain use, but I think down the road it's going to be very, big as well. So I'm going to talk about that as well. So this is a gentleman, in my office, and then I'll just stand over here. I'm afraid I'm going to block your view. So these are a very common question when I see a patient in the office, and I kind of discuss about you will need a device, and the question, one of the most commonly asked questions is this a pacemaker or defibrillator? And I would say not only you, but also ER doctors, family practice physicians, or my general cardiology colleagues, sometimes they really don't know the difference between these two. And sometimes they use these intertwined, and to me, these two are very different, right? To me, these are very different. And you can see the devices on the table, you feel them, they look very different. And since some of you may have these questions, I'll just kind of elaborate this a little bit. Pacemaker doesn't shock you. Defibrillator can shock you. Okay, that's a major difference here. The difference between when we consider pacemaker and when we consider defibrillator is really because of that. If somebody, we think we need to protect this patient because they may go into something we call it a funny rhythm or a very fast rhythm or something we call it ventricular tachycardia, then we consider defibrillator. Defibrillator, if you see that on a hands-on, session, they're much bigger. Why? Because they have to store energy to shock a person. Pacemaker is much smaller. Okay, pacemaker won't shock a person. You should not feel whatsoever the pacemaker. You should not. You should not feel your belly is bumping. You should not feel it twitching. You should not feel anything. Technically, you should not feel the defibrillator shocking you as well, because by the time defibrillator shock you, you should be out. You should be unconscious, and the defibrillator will rescue, to shock you. Another thing I often get questioned is, I thought it's a defibrillator, why is pacing me? So all the device can pace a person, but only defibrillator will shock you. You don't feel the pacing, all right? If your device is stimulating you 20% of the time, 100% of the time, 0% of the time, you feel the same. You don't feel that pacing. But if the device is shocking one time, you will know it. You know, yeah, especially when you're awake, right? So this is one of the commonly asked questions. How big is it? I'll just answer that with your, just feel it yourself. And sometimes in the office, I'll try to bring one of them and let them feel it. It's quite small. And these are the traditional, the leads inside the blood vessels, right? So some people ask about this, and some of them actually they really don't want to have the device because they think once they have a device, the battery needs to be replaced very often. And I tell them depends on how much you use it. Similar to a car. Definitely not as often as you go to a gas station. It's not like that. But generally speaking, the ballpark is about 8 to 12 years. 8 to 12 years. If you use it a lot, so for some patients, they use it a lot, it's much shorter. For some people, they don't use it at all, really, it may be longer. But I tell the patient ballpark is about 10 years, 8 to 12 years. That's kind of a ballpark. And the battery change out is really simple. In and out of the hospital, you barely fall asleep, and procedure is done. And really, the battery change out is pretty straightforward. So I wouldn't use this concept as a hinder to get a device if the patients really need it. And that is a question I get asked a lot. And this is a question you have to ask your doctor, because this is really what you need to ask. Will I feel better? You need to know this answer before you sign up for any procedure. Will I feel better? Or will I live longer? Will I have less, complications or anything? And I tell the cath lab staff as well, all the doctors, whether you're an orthopedic surgeon, you're a cardiac electrophysiologist like me, or urologist, or ophthalmology, you do all the procedures on every person for two goals only. Two goals. One is to make this person feel better. You replace a knee, you change a cataract surgery, you put in a pacemaker. Second is you make this patient live longer. make this person live longer. You save this person, put in a stance or, put this patient on some medications. They may not feel better, but they live longer because of, reduce so and so. And for us, in terms of cardiac devices, we put in pacemakers primarily to make the patient feel better. Patient can survive just fine without a pacemaker. But when you put in a pacemaker, there's a chance this patient can walk better, less short of breath, can walk farther, can keep up with their friends, play cards and all those kind of things. Some of the conditions you do extend lifespan. There are some malignant condition, we call it heart block. You put in pacemaker and this patient can be saved, the life can be saved. By and large, the defibrillator, if it's a regular garden variety defibrillator, the patient should not feel much better. But then we are making this person potentially live longer because you protect them from something that is preventable. There is a special pacemaker defibrillator, and I'll kind of talk about that with the diagram. That one, you have a 70% chance you'll feel better and your heart function can get better. So this is a diagram I was talk to you about. So most of the pacemaker have one wire that goes to this chamber. So this is a person, they kind of look at you. This person's left side, this person's right side. So this bottom right side of the heart is where the wire go. And how this wire gets to your heart is actually like a screw. And literally it's a screw. You can feel it. If there's a wire over there, you can see it. And you basically rotate this wire and the screw will extend. And that screw will screw to your heart wall inside. Right? So it's really no rocket science. It's really a screw. So as you can imagine, once you have a pacemaker, initially the screws are fresh, like you just have a nail hit on the wall. If you pull hard, it can dislodge. That's why we have all these arm restrictions. If you have loved one or yourself getting a pacemaker, you recall there is arm restrictions in the beginning to allow these screws to be mature inside your heart. Once your body kind of grow some tissue over it, it becomes harder to dislodge. But we typically allow the first 2 weeks with some arm restrictions, especially the left arm, because you're going to pull with your left arm movement to allow that screws to be secure inside the heart. A lot of times we do another wire to the top chamber of this right side. We call it atrial lead. And then, in certain heart situations, your doctors can decide patients will benefit from a third wire that goes to the left side of the heart. And the way I explain to the patient is that you have a weak heart, your heart, especially with some electrical delay, your heart, left and right, they're not in sync. It's as if you want to squeeze a balloon and you can squeeze with one hand at a time. Very inefficient. So with one wire on the right side and the other on the left side, you squeeze them together, right? So it's more efficient. Squeeze your balloon with both hands together. And this is sometimes I refer to special pacemaker defibrillator. I said it's a Lamborghini device, or medical term is biventricular pacemaker defibrillator. It can be a pacemaker only with this 3-wire device, or it can be a defibrillator. But the idea is to squeeze the heart from both sides. And not every patient will qualify for it. You have to have some electrical delay, and your doctor can look at their EKG and tell you if you're a candidate for that. So this is another person. Basically, she asked around the procedure itself, because now that you kind of have some basic understanding about the devices, you have a big picture. Now you wonder what happened on that day. So this person is going to ask, am I awake for the surgery? Is it dangerous? Okay, so the answer is we try
try our best to make sure you don't remember anything. Okay, these type of procedures generally are done under something we call a moderate sedation, which is between no sedation and general anesthesia. There is a gray zone. We give you some sedation agents to make you don't feel much pain and don't remember much, but some people that might remember, might be awake. And the procedure generally for a straightforward device take about less than an hour. So really, there's no point to request anesthesia for, such a short duration. Is it dangerous? It is still an invasive procedure, so there are some intrinsic risk of complications for any types of these procedures. The procedure overall is less than 3% overall, so it's quite safe for this type of procedure. It's not an open heart procedure. We run minimally invasive through the blood vessels. Most of the procedure, the traditional one, goes from your left shoulder area. I put in right side devices in the right shoulder for several occasions. One is if the patient has some issue on their left side, history of breast cancer, some issues, skin lesions over there. Some patients are left-handed. Especially if they shoot with their left arm, then I put on the right side. Especially a pacemaker, because pacemaker, I don't care which side, but I don't want this patient to, have some life limitation, Some people, they wake up, their pacemaker on the left side, they have to give up their hobby. And if it's elective, we kind of try to make it more suitable for the patient's lifestyle. You can potentially damage the blood vessel, damage the lungs. You can potentially have bleeding, infection. The wire can fall off the heart wall. There are some potential, unwanted results from this type of procedure. It's not like you do 1,000 patients, 1,000 patients will be okay, but it's kind of rare events, and we kind of do our best to prevent these complications. So it's not dangerous, but there are potential complications. How long do I stay in the hospital? When I was a electrophysiology fellow at Northwestern, that was, probably 6 years ago. All the new devices, they stay in the hospital overnight, all of them. And I think they still do them. So it's case by case. There are some hospitals and they still keep all these devices overnight. Most of, I think my colleagues and I included, I think we send the patient home the same day for a lot of reasons, for patients' requests. And, I think the longer a person stays in the hospital for this type of procedure, the higher risk of infection. So if a patient requests to be in the hospital overnight for so-and-so reason, I think I have no problem with that, but the general rule is send home the same day. Recovery and restrictions, I kind of touch upon that. So generally speaking, I tell the patient to take it easy for about a couple of weeks. So for the traditional device, if we put it by the left shoulder, we generally tell the patient, don't raise their left arm above their head for about 2 weeks of time. For the reason we mentioned about earlier, because you don't want this wire to dislodge. Another thing is we don't want the incision to, have some tension on the incision as well. You can do everything from the right arm. And another thing is we don't want the patient to have a rigorous shower. You can shower with our dressings, but try to pat it dry as much as possible. And then don't let the water get into the wound. Generally speaking, we have a device clinic follow up in about a week after all the fresh device implant, just to check the wound and everything. And the restrictions are, kind of I mentioned. So this is dressings we routinely use over here. It's called Aquacel. I relocated from a private institution and this was, quite expensive. You have to really, ask for it, but here it's routine here. So it's quite nice here. I don't have to ask for it. And this is kind of a nice dressings. You can allow patients to have a shower. Previous they use something called Tegaderm and you have to no shower for a week, in which, I have a lot of patients in farm and during the summer, no shower for a week is pretty terrible. So I think this is a great invention. When can I go back to work? And then the answer is, it depends. Depends on what kind of work you do. If you work, so if you're retired, you don't work, then really there's no question. But if you work in a very strenuous activity, truck driver, you have to load or you have to get on a tractor and do a lot of, weightlifting or those kind of things. Generally speaking, I said 2 weeks, take it easy, 2 weeks. But if you do like teacher, desk job, not involving a lot of physical activities, you can theoretically go back to work the next day, So it depends on what kind of work you do. All right, so this person asked about some of a more of a question, how do you live with a pacemaker or defibrillator, right? So once you have it, you survive the procedure. Now you get home, so what? What do I have to watch for? And so a commonly asked question is, and the reason why patients ask these questions is sometimes you have to ask them because some of them, they have a lot of reservation about a device. And unless you ask them what's your concern, they won't let you know. And really a lot of concerns are embedded in patient misbelief sometimes, unfortunately. They see or they hear from their friend or and you have to really delve into what the patient's concerned. The patient has no problem getting a pacemaker. They have a bypass surgery. They don't care. But somebody told them once you have a pacemaker, you cannot use, for example, you cannot go through an airport, you cannot travel, you cannot have a cell phone, you cannot blah, blah, blah. Then they don't tell you that, but they will keep pushing out of this idea of having a device, even if they know this is probably going to help them. Question, can I use cell phone? The answer is yes. Okay, the answer is yes. However, and I always tell the patient yes until 2 years ago when they started to realize there are actually some cell phones that can actually inhibit or interact with your device. And so this is something we call it wireless charging. It's iPhone 12 and up. I think I don't use the iPhone, but I think the iPhone is a 14 now. So iPhone has a feature called MagSafe. If you flip your iPhone or something, there's something on the back that allow you to do a wireless charging. And the way they allow you to do wireless charging, they increase the magnet power on this iPhone. So usual weak magnet is not going to be doing anything. The one that typically put on the, like when you go to Hawaii, you buy those magnets on the refrigerator, that usually doesn't cause a problem. But if your magnet power is strong enough for devices, it does strange things. Let's just call it strange things. It can make your pacemaker get excited just to pace you no matter what. You're almost like you're trying to fight your own rhythm. You may feel kind of funny with the pacemaker. For a defibrillator, it's even worse. If you have one of those big magnets on your defibrillator, then it's going to disable that defibrillator, seeing if you're going into trouble. So for a variety of reasons, try to stay away from a strong magnet field, right? So nuclear power plants or those kind of things. So this is actually they recommend if you have a MagSafe, you should stay away from the device 6 inches. So don't put it by your left upper pocket. If you can, because that will be very close. Put it on the back of your pants, probably okay. When you do wireless charging, try to keep a further distance because they create a bigger magnetic field. If you don't have an iPhone, probably okay. You know, I think you can switch to Android. This is a commonly asked questions as well. You know, can I go through a metal detector? You know, if you go to a arena or something, they do this kind of things to make sure you don't have a gun or metal detector. Generally speaking, if you walk through fast, it's not going to cause any problem. You're not going to stay in the metal detector for 2 hours. You know, you're going to go through that, and it will set off the alarm. These devices are made of metal. It will set off the alarm, and you know, all you have to do is tell them you have a pacemaker or a defibrillator. They have X-ray, they can see it. If not, then you just show them your car, and really, it's inside you. You know, you can feel the device. If it's inside you, you know, they know you don't have a gun or anything. Oh, go ahead.
Yeah, what about when they want you?
Yes. So when they want you, you will be, yeah, it's a metal. If it's closed, they will see it. But again, they can see there's a device over there. Yeah. So, yeah, and you can certainly take a flight. You know, once you have a device, you can certainly take a flight. That's not a problem. However, I have patients ask me once they have a pacemaker, if they are gonna get to a flight within that 2 weeks of time, you know, I tell them, be careful because you're gonna handle your luggage, overhead bin and those kind of things. You're gonna violate your restriction. So if somebody else can do that for that person, it will be fine. Can I use microwave? Answer is yes, okay? Microwave is known to be harmless for these devices. Can I have MRI? So generally speaking, and unfortunately, I think there are still MRI non-conditional device circulating, all right? So if somebody already has a implant that prohibits this person of MRI use, for example, you know, some metal inside, so this patient can't have an MRI anyways. You can arguably put in a non-conditional MRI, not MRI conditional device, but for the most part, the new devices are all MRI compatible. But just remember I said, you cannot just go through an MRI yourself. You have to, you know, let us know. And the radiology department will let us know. We will, you know, provide the appropriate service before and after. All right, so this is a younger person, and she was asking about some sort of a longer term issue. Okay, so, you know, she's wondering, all right, I'm getting this device at the age of 40. What's going on? You know, I have several decades to live. What can go wrong? So the device is very good. All right, these devices are made of IC, those chips. They're, in my opinion, they're reliable, way more reliable than your own heart. Our heart is made of meat. It's not reliable. Unfortunately, you know, these are biological things are known to create some errors. Computer, yes, you can create errors, but for the most part, it is without any external force. The computer inside these devices are very reliable. What is not reliable are these wires, are these leads that goes to your heart. These are purely mechanical, and then with your, you know, body movement and everything, they're prone to develop issues. You can fracture, you know, you can cause a lot of situations, and your body has some infection. The bacteria can circulate from your bladder or your lungs and go all the way to these foreign bodies and kind of find a home there. When they find a home, it kind of forms something called vegetations. And once you have a vegetation on the wire, it gets disseminated. It can't be eradicated by antibiotics, and you have to take it out. So a lot of time we're dealing with these issues where the wires have been in place for 10, 20 years, and then now something is wrong, and or it got infected, we have to take it out. So these are really the long-term issue. And once we take it out, it almost look like this. These are not uncommon. You see the wire, you know, there's always some debris or tissues your body is trying to grasp, you know, it. So putting a device in can be challenging, but removing a device or removing a wire that has been in place for, generally speaking, more than 2 years, more than 10 years is really difficult. More than 2 years becomes difficult. So the reason is, once the wire is in your blood vessel, the body is gonna form scar around it. Gonna grab some tissue over it. This tissue will look like this. And when you just pull the wire, it's not gonna come out. You have to resort to some sort of help. And the help are basically two. One is a thermal force by laser. You know, you kind of use a laser to dissolve this tissue. And second is use something called mechanical cutting that cut through this tissue. And both methods kind of involve some techniques that remove the wires without tearing the blood vessel. And tearing the blood vessel is always a concern for these type of things. And if that happens, you need to have a surgeon open the chest right away. And that's why in this hospital, if somebody has a wire that is in place for more than 2 years, you know, by and large, generally speaking, we have a surgeon to be on standby. Perfusionist, everything, we do it on the hybrid room. We prepare for the worst case scenario, right? So this occurs very rarely, but you cannot do this and then ask for a surgeon when you need help. If the surgeons are not ready, this patient's die on you. So this is something that potentially can occur, not necessarily always. And a lot of time we have everything ready and the lead just come pull right out. You know, it's not predictable, but we always prepare for that 0.1% worst case scenario for this type of situation. Yeah, pretty nasty. So that comes to kind of alluding to the idea, there are some devices without wires, you know, because the devices are pretty safe, pretty smart, but the wires are the issue. What about just putting a device without any wires or anything in the blood vessel? So this is something we call a leadless pacemaker. Okay, so there's some demo over there. There are so far 2 companies, they have manufactured this type of things. So the leadless pacemaker goes through the groin, right? So instead of having a pocket in their left shoulder or right shoulder, wires inside the heart, these are like a bullet, pretty small. It goes from your typically right side of the groin, go up to your heart, and we put in this device inside the heart. And procedure is quite quick, quite fast. And you know, the results are quite nice. And the patient really, the restrictions are on the other, you know, no arm restriction whatsoever, but you have groin restrictions. You know, you take it easy for about a week. This right now, we only put it on the bottom chamber of the heart, so you cannot stimulate the top chamber. That is a big drawback of this existing device. But otherwise, you know, the battery, and they're coming out of the newer version with a longer battery. So the battery now typically lasts for about 10, 12 years. In the future, will be longer. And for a normal size person's heart, you can probably put in 3 or 4 of them. So if you're over 50 years old, you're home free, unless you live into 150 years old. You know? And we don't generally remove these type of things. So these are called leadless pacemaker. And for defibrillator, we have something we call a subcutaneous defibrillator. All right. So instead of a traditional defibrillator, we put it by your left shoulder. We put in this. These are subcutaneous. These wire are tunnel underneath the skin. So the device is by your left axillary region. It's much bigger can. Maybe they have a demo over there. You can feel it. Generally speaking, these are a pretty good option for people who are younger. So they, you know, they don't have, because when you're younger, you have more chance to develop lead-related issues. So it's more, you know, palatable to put in one of these devices when the patient is younger, especially this defibrillator. There are some drawbacks of this existing device. It cannot stimulate your heart when your heart rate is slow, right? So there are some drawbacks for these devices, but the benefits are obvious. You know, you don't have, and they still this one still require battery change out every few years, you know. This one, we just put another one next to it. So this is your grandkid or your great grandkid was asking you what is new on the horizon, you know. So they're 5 years old, they live up, you know, grew up with a cell phone, internet. So he's wondering, when he gets to your age, what may be new on that kind of frontier. So some of them are already developing, or we're doing it right now, but some of them are really almost like imaginary right now, and there are startup and they're, you know, putting efforts in doing this. So one of the trend for current era pacemaker is something we call a conduction system pacing. So this is that diagram I put up earlier. So traditional pacemaker, we stimulate your heart from, you know, around this area. And people have found if you stimulate your bottom chamber of the heart in this random place a lot of time, more than 40%, and a lot of patients are getting stimulated 100% of time. Some patients, they will develop a weak heart, and you don't know when or how or who, you know, basically you kind of keep a close eye on those patients. If I have patients with more than 40% of a usual side of pacing, you know, in the bottom chamber, I generally do an echocardiogram every other year, or when they complain of some symptoms. Just be on the lookout for development of cardiomyopathy or heart failure. And the solution is to add another wire to the left side of the heart to squeeze their heart from both sides. But lately, there has been a trend to stimulate your bottom chamber through your normal cable. So instead of stimulating your muscle, you stimulate the cable. So instead of plugging the cable to a random wall, you plug in the cable to a cable behind the wall, so to speak. And the results, I don't know how it projects from the back. So this is actually one of the patients before the pacemaker was placed, you know, stimulating somewhere randomly, and you create this pretty wide EKG complexes. EKG complex, when they're wide, that means you're slow, right? So the horizontal axis is time. So the wider it gets, it becomes slower. So that means your heart is left and right, their conduction pretty slow. Once we move into a conduction system, it becomes much narrower. This is almost normalized. Almost normalize the complexes. That's almost like a nature. You know, when most people are born, their EKG, you know, you look at the wave, it's very sharp. Sharp means narrow. Narrow means good, right? And when you become wide, you know, the left and right, they're dysynchrony, and this patient feels better with this, right? So there are a lot of benefits with this type of pacing. It does require some of techniques and, you know, some time doing the pacemaker, and a lot of time the patient would actually benefit from those. Not everyone, but, you know, I think this will be, and all the companies are developing tools to allow better deployment for this type of conduction system based. And this is another investigational devices that I actually helped put it in before I came here, my previous job. So this was first patient in Illinois, something we call a leadless pacemaker. But right now, the leadless pacemaker only put in the ventricle, the bottom chamber. But this is the first patient who has a leadless pacemaker in the top chamber, called atrium. And this will open the door for people who really don't need bottom chamber pacing. Actually, predominantly is the top chamber. And another benefit of this device is this device, you can actually grab it and then unscrew it and take out. So instead of leaving it in and put another one, you can actually replace it, right? So there are some additional benefits for this type of device.
Question,
Yes,
are those synchronizing with each other or are they?
very good question, very good question. So yes, they talk to each other.
Oh,
Just like your pacemaker with two wires, they talk to each other. And that's the reason we have to make a certain angle and then make a certain distance. And that's a very good question. And that is one of the struggles, I think, when they came out initially and, but I think, they talk to each other. There's a, way we can assess how well they communicate. And it's pretty good, pretty remarkable. And that diagram looked like this. So when we say, and that's a little bit more advanced knowledge, I don't expect you to know everything, but when we say they talk to each other, think about it, your heart, without a pacemaker, they talk to each other. Your top chamber beats, your bottom chamber knows to follow. Why? Because you have cables in between that connect the top to the bottom. When you have a pacemaker, there's no cable in between. Your cable is destroyed or your cable is diseased. That's why you need a pacemaker. So those patients, they need to have a certain, something we call it programming, right? So when you see that big machine over there, that's something we call a programmer. When you have a device, we go to the office or device clinic, people will put a wand over your device and do something they call interrogation, programming, reprogramming, and those kind of things. And that a lot of things are what we think that is right for you. A lot of things are nominal. A lot of things are subject to basically case by case scenario. So one important lesson is if you get a device, especially a pacemaker, also defibrillator, if you feel no dramatic improvement, don't just say that, all right, I have this pacemaker, it's useless. Don't say that just yet. It may be really useless, but before you give up on that idea, we can check your device and see how the device is performing and how there is any room for tweaking the programming, right? So I actually came over, just saw a patient who his heart rate average about 50, and he got this device. And he said he got this device about 3 months ago. He didn't feel any difference. And he was disappointed because he was promised this device is going to bring his, a new chapter of his life, etc. But I look at his pacemaker, his heart rate is really spending about 90% of time when the heart rate is at 60. So his pacemaker is setting at the heart rate of 60 and above. Remember I said there's a rate response, track his activities and etc. But it was not very sensitive somehow. And he's a quite active person, so he's quite disappointed that the pacemaker doesn't provide him with faster heart rate. So what I did is reprogram his sensitivity or the rate responsiveness to a little bit more sensitive so that, I don't know, I just saw him, but I said, see how you do. And these are all programmable, which means if he feels okay, but he can do more. And the next time I just see him and I see his heart rate plot, I know if it's too much, enough, not enough, I can always tweak it. So when you have a pacemaker, you feel like, all right, I feel great, then nominal setting works for you. And nominal setting actually works for a lot of people. But if it doesn't work for you, don't give up just yet. Just, request an appointment or we can try to reprogram it. So this is one of the slide and, how do I do on time? I'm kind of doing pretty slow. Let's see. 6:30, all right. So this is a device, I'll just quickly go through. This is not a pacemaker, not a defibrillator, but, it's a newer device and we have a contract with this and, it is supposedly will improve your heart function. It's kind of working in a different mechanism. It stimulates your heart in a critical moment. For some patients who don't qualify for existing device with significant heart failure symptoms, this is a device that can, potentially help. And, and this is another kind of device by one of the company. So they kind of incorporate a leadless pacemaker and a subcutaneous defibrillator so that, it allow, so the big drawback of this defibrillator is it cannot stimulate your heart. And obviously this pacemaker cannot shock you. So now with this, you have a total extravascular system, which can do everything. So this is kind of nice concept. And I think this will be a future trend as well. This is another company that manufactures this device that is smaller in size in the X-ray region with this wire that goes underneath the breastbone. So it's closer to the heart. It can provide some therapy that the current existing device cannot do. So to summarize, the future development, even longer battery life. They're gonna go wireless charging, I think. It's eventually. They're gonna make money somehow elsewhere. They're not gonna make money just out of the can. Wireless charging. So eliminate the need to change out the battery. It's kind of a stupid procedure in my opinion, but it's just the way it is. It's quite straightforward, but I feel like we should do better. We should not do this every now and then. Biodegradable materials, why not make everything biodegradable? You inject the pacemaker cells that goes to your heart and start beating. It'll be nice. Now the pacemaker sends your activity, sends the arrhythmia, sends how much you're being paced, sends the battery, all that kind of things. But why not sends your oxygen level, blood sugar, blood pressure? These are multiple sensors. Gene therapy, you have some wires, some needs inside your heart, and this person has heart condition. Why not use your device to deliver local gene therapy? And obviously AI, AI is going to be revolutionary how we think, how we do things. You cannot trust the college students' annual essay anymore because they're all generated by AI now. So, but if you can use the AI to do better things, we still have a lot of existing conditions of existing technology, and I think AI eventually is going to solve a lot of them. All right, sorry, I'm a little bit late on time. If you have any questions, yeah, go ahead.
We all know people between the ages of 40 and 60 where you hear died suddenly, unexpectedly. Should they have found their way to you? Also, where do 3D printers fit in for the future?
Okay, so people who die prematurely, 40, 50s, or even younger, unfortunately, a lot of times they don't make the way to us unless they get revived and they try to investigate the reason. Because the chance of survival out of hospital cardiac arrest survival is about 1%. The chance of out of hospital cardiac arrest survival without neurological impairment is way less than that. That's why you need a defibrillator in some patients. If you have so when I tell patients to have a defibrillator, pacemaker is slightly easier to understand. When I tell the patient you need a defibrillator, especially the one that they get referred to me because their heart function is weak, those patients, they get a defibrillator, they're not going to feel better. And I tell them, you're not going to feel better with this device. This defibrillator is like a life insurance or a seatbelt when you drive. You're not going to, you can still drive without a seatbelt. But this is going to prevent something that is preventable. About 30% of people with a weak heart, they're gonna eventually need it. And 30% is minority, but it's a quite sizable population. Think about it. And this is not, oh, you cannot see from one eye. It's not, you cannot walk. This is life and death we're talking about. So some of the patients, they're older, but they are still functional. And they don't want it. And I say, why? Because I don't want to be a burden of my family. I've heard that sometimes. And I really delve into why they don't want to cannot move on a breathing machine in a nursing home and kind of become a drain of their family financial situations. I tell them, with this defibrillator, you're probably less likely to develop that kind of situation. The worst is you have a cardiac arrest when you're in a restaurant. Some people do a CPR on you and you're intubated and you go to the ICU for so weeks and go to a nursing home. That's a possibility. Whereas if you have a defibrillator, if you go into this funny rhythm, you simply pass out and wake up, feel like nothing happened. That's really what happened. So a defibrillator, yes, obviously it's for somebody who is bedbound, demented, life expectancy less than 1 year. You don't recommend that. So 3D printing, first of all, it's not going to be FDA approved. I visited one of these machine factory in Minneapolis. They are under heavy scrutiny. All these devices that goes into a person, they're not, they're for right reasons. They're heavily scrutinized. You cannot print something and then put in another person's heart. There's no way. I think for regulations.
Well, help me thank Dr. Shen.